Good morning. I'm Meredith Williams. I'm one of the perinatologists at Northwest Perinatal. So I am talking today about late preterm steroids. And the reason this came up is now this trial has been, the ALPS trial, which looked at late preterm steroids, has been out for about 2 years. And there's been a fair number of good uses, bad uses, more controversy related to it. So it seemed a sort of a timely topic to revisit. So I'm going to start with presenting the original study, the ALPS trial, which basically most of this, where our protocol has come from, and then give a little bit of some of the newer data questioning maybe the utility of late preterm steroids. So overall, about 70% of preterm births occur between 34 and 36 weeks. So steroid administration less than 34 weeks has absolutely been shown to be of benefit for those babies, and we've been giving it for years. We know that those babies do well. It does not seem that there are any long-term side effects for those neonates after a short course of steroids. There was data before that, one course is good, more is better, and actually more was not better. There was looking at weekly steroid administration, and those kiddos definitely had some issues with head size. So we went away from that, and then a paper came out looking at rescue steroids and looking at a single course, but it was not in this late preterm period. So that was really the focus of the ALPS trial, was looking at steroids being given between 34 and 36 weeks. The problem with that is there's really not a lot of data on long-term outcomes for kiddos that get steroids at greater than 34 weeks. There was a trial called the Aztec trial that came out in a couple years now, looking at giving steroids even greater than 37 weeks for kids being delivered by C-section, and there was some benefit, but there's just really not a lot else out there about sort of long-term neonatal outcomes. So the ALPS trial was originally published back in 2016, but was presented at SMFM earlier than that, basically looking at infants that were born between 34 and 36 weeks of gestation, and that goes up to 36 and 5. And we know that those kids are at a little bit higher risk for having respiratory compromise than kids that are born at 37 weeks gestation or later. So the trial really looked at those specific kids, and the moms were randomized to either receive 2 doses of steroids, similarly to how we give them before 34 weeks, or a placebo about 24 hours apart. The primary outcome, which I think is really important to note, was a composite. So it was not one specific outcome. So they actually had to look at neonatal composite outcomes in order to show any clinically significant benefit. And basically they were looking at treatment within the first 72 hours, stillbirth, or neonatal death within the first 72 hours after delivery. And those composite outcomes were CPAP for a couple of hours, just nasal cannula supplemental oxygen for over 4 hours, ECMO, or the need for mechanical ventilation. So the inclusion trial, so this is where that sort of uses and abuses comes into play. The gestational age has to be between 34 and 0 and 36 and 5, and for those patients who have an increased risk of delivery before 37 weeks. So some of that's a little bit like the magic 8 ball, trying to predict who's going to deliver before 37 weeks and who should get it and who shouldn't. And so that's a little bit trickier. It's patients who are admitted with preterm labor, with a cervix between 3 and 8 centimeters dilated or greater than or equal to 75% effaced. Patients who are admitted with PPROM with less than 6 contractions an hour or less than 3 centimeters dilated. And in those situations, oxytocin is actually withheld for 12 hours to get that first dose of steroids on board. The exclusion criteria, which I think is probably the more pertinent part of this discussion, and this is where we have seen more of the abuses, is patients that really don't meet the criteria are being given late preterm steroids. So if delivery is expected to occur in less than 12 hours, they are not a candidate. Their cervix is over 8 centimeters. If they ever got steroids. And so I think that's one of the #1 things that I've seen up on labor and delivery is this is not rescue steroids. This is a very different protocol. If they are having stress dose steroids because they're on chronic steroids, if they are diabetic, either type 1 or type 2, gestational is still allowed to get, is still allowed to be included in late preterm steroids, but pre-gestational is not. if they have multiple, if they have major anomalies, if they have choreo, and there's sort of a whole long list of other exclusion criteria, but I think for our purposes, these are the really most important ones that are really clinically applicable on a day-to-day basis. So the outcomes, I think here, oh, sorry, there's a duplicate in there of the reduction in neonatal respiratory morbidity. So basically, composite, look at that, it's 14.4% down to 11.6%. The majority of that, however, is TTN, so transient tachypnea of the newborn. There is no improvement in respiratory distress. There's no difference in the short-term outcomes overall for respiratory morbidity. So it is a very small, so it's a research significant with a significant p-value, but the question is whether this is actually clinically significant decrease in respiratory morbidity. Neonatal hypoglycemia was more common. So in patients that got the placebo, 15% risk of neonatal hypoglycemia. In patients who received the betamethasone, 24% of those babies had hypoglycemia. The number needed to treat to prevent one case of composite respiratory morbidity is 35. The number needed to harm, and most of which, again, is neonatal hypoglycemia, is somewhere in the 11 to 14 range, depending on which study you look at and which sort of editorial you're looking at. So some of the concerns that were raised by the ALPS trial was, the number one is the neonatal hypoglycemia. So kids are being admitted to the NICU less maybe because of TTN, but maybe there's more treatment that is involved because of the hypoglycemia, more pokes, more blood sugar evaluation, more interventions for that. There's only a very modest benefit in respiratory outcomes, and we don't know what the impact of that large dose of steroids is on the late developing third trimester brain. There's also no long-term data on neurodevelopmental outcomes. There's also some studies showing that exposure to betamethasone may result in insulin resistance in the offspring as adults. So that certainly in the era of obesity and diabetes is of concern that we may be making that worse. The other concern that's been raised out there in the literature is this very rapid adoption by both ACOG and SMFM. Usually we are not sort of the first at the starting line to adopt stuff just because we've got vulnerable patient population. And really, there was a very rapid push by both ACOG and SMFM to consider giving late preterm steroids. So there was a New England Journal editorial by Crowther from MAG fame, this article, and they were really pretty concerned about the hypoglycemia. And the concern was that neonatal hypoglycemia has been an independent risk factor for developmental delay in preterm infants. So are we taking away a small risk of TTN to cause developmental delay and long-term neurodevelopmental complications? The other things that they talked about in that editorial was that maybe there is a reduction in time until the first feeding, a small decrease in the risk in the stay in NICU, and maybe there was a decrease in cost, but there was no economic cost analysis looking at that. So there was another article published just in January of this year looking at, again, the ALPS trial, and they looked at the difference in neonatal hypoglycemia among kids who got late preterm steroids, and again showed that higher risk of developmental delay. In their trial, they again confirmed the number needed to treat was around 35, but the confidence interval is huge, from 19 to 259. So that's a really pretty big confidence interval to treat. Theoretically, think about treating 259 babies to prevent one case of TTN seems a bit extreme. Their concern in their article was also that the babies that are at highest risk for neonatal complications, admissions to NICU, respiratory complications, so multiples and diabetics, are excluded from the trial. And so maybe there are benefits to those babies that would sort of sway us one way or the other about late preterm steroids, but they were excluded. So Crowther looked at the impact of gestational age and maternal hyperglycemia on neonatal hypoglycemia. And basically, they they hypothesized that babies given late preterm steroids in that same window that the ALPS trial was had a higher risk of neonatal hypoglycemia than earlier preterm steroids, and that maybe maternal hyperglycemia mediates this risk. And they were looking at neonatal hypoglycemia to blood sugars less than 40. So they looked at babies' blood glucose, and it was on average lower than babies of moms who did not get late preterm steroids, so 56 versus 62. Now, neither of those are levels where babies would get treated, but again, if you look at that confidence interval, there's still a potential for more kids to be affected. The risk of neonatal hypoglycemia in their trial they found was twofold higher with late preterm steroids, which is similar to what the ALPS trial showed. There's no difference in mom glucose values for those with and without neonatal hypoglycemia. So we know moms get hyperglycemic in response to steroids, and we can't really use that to predict which babies are at risk. Even if moms have hyperglycemia at delivery, there's really not a significant difference between those that have the babies that have neonatal hypoglycemia and those that don't. There's no significant difference in neonatal outcomes, hospital days, hypobilirubinemia, or other outcomes. So this was just presented at SMFM's annual meeting just in January of this year. There's another study in 2017 that was looking at babies that are potentially at the highest risk of pre-pregnancy diabetes and choreo again. And what they found that the majority of late preterm deliveries among those that were eligible for antenatal steroids are occurring at 36 weeks and later, but the majority of the respiratory complications are among those at 34 to 35 weeks. So the babies that probably need it the most are not really the babies that are necessarily getting it, and the babies that are getting it are not necessarily those that really need it. So key points are that as you're thinking about whether or not to give late preterm steroids or not, there's really very limited respiratory benefit overall. It's about a 3% reduction in risk, most of which is transient tachypnea of the newborn, which you could argue is not pathologic, and maybe, yes, does need some respiratory support, but is not necessarily needing such an intervention. There's a significant increased risk of neonatal hypoglycemia, which may have also cause NICU admission, but may also be linked to lifelong issues like developmental delay and insulin resistance. The number needed to treat is high compared to the number needed to harm. There's no long-term follow-up as far as the developmental outcomes for these kids, and there's the potential for long-term adverse outcomes. So appropriate patient selection is really important. Careful counseling is really, really important. So on labor and delivery, we have these laminated sheets that can help with that counseling. It goes over the inclusion and exclusion criteria and some really good talking points. I have found that generally speaking, when I counsel patients, I have yet to have one who actually wants late preterm steroids after being presented with the data. I've had patients where, you know, there's been a preliminary discussion, and then I am consulted to come in and have more of a discussion, and they again feel like, hey, maybe this is not the right thing for my baby. So I think really patient selection